Hello, I'm Dr Simon Petrides, musculoskeletal and sports physician from the Blackberry Clinic Group, where I'm medical director. And this talk today is on dextrose prolotherapy in musculoskeletal pain. It is designed for sport and exercise medicine doctors, musculoskeletal medicine doctors, podiatrists, and physiotherapists. And what outcomes are we likely to be learning today? Well, what is prolotherapy? You'll find that out. Can it help your patients? That's particularly important. Can you use the technique yourself? And will it enhance your practice? And where can you learn to do it? Now, prolotherapy started maybe as much as 500 years BC, when Hippocrates used it by helping javelin throwers with dislocating shoulders using red hot pokers. George Hackett started using it actually to prevent hernias by thickening connective tissue. Gus Hemwall took this on and decided it would be more relevant for musculoskeletal disorders. And Geoffrey Patterson, who's only recently died, also took this further. Milne Ongley did some more research, which was published on the subject, and James Syriacs actually brought it to this country when he was working as a consultant at St Thomas's. So what types of prolotherapy are there? Well, hypertonic dextrose is one of the commonest used in the world today at several different percentages. Sometimes this can be augmented with a 1% phenol solution. I use this particularly in the lumbar spine. Other types of prolotherapy and regenerative medicine also include autologous blood injections, platelet-rich plasma, and stem cell treatments, which are being heavily researched at the moment. And in fact, dry needling and shockwave therapy are also forms of trauma through which the healing process is initiated and connective tissue augmented in terms of blood cells migrating and creating a thicker collagen. So in terms of the actual actions of a prolotherapy injection, it does actually restore and increase the strength of connective tissue. The collagen fibers get thicker. Ligaments, tendons all have collagen fibers in them, as do the joint capsules and cartilage. So the resulting action is to stabilize joints and reduce the forces of degeneration in, for example, the knee as a result of minor instabilities. There is also a neuromodulatory effect from 5% dextrose on sensory A delta and C fibers and their ion channels. So what are we using prolotherapy to treat these days? Well, chronic low back pain is one of the most popular, mostly low back pain that is due to instability and sacroiliac joint dysfunction, coccydynia, pubic symphysis dysfunction, otherwise known as pelvic girdle pain. And I see a lot of this in my clinic in Milton Keynes. Osteoarthritis, there's been some recent research on osteoarthritis of the knee, particularly with some beneficial results using dextrose. Patella subluxation, patella alignment issues, biomechanical issues, and anterior knee pain is a common problem for which we use prolotherapy. Retinaculitis, pain on the edge of the patella, and Osgood-Schlatter's syndrome, interestingly. All of these have been backed up by research. Tendinopathy, apart from tennis elbow, obviously, and golfer's elbow, there's gluteus medius tendinopathy, patella tendinopathy, Achilles tendinopathy, plantar fasciitis, medial tibial stress syndrome, etc. The coronary ligament pain in the knee from torsional movements can be benefited from dextrose injection, as can grade 1 and 2 partial tears of the medial collateral ligament. Superior fib joint instability and pes-anserine tendon pain. Classically, any joint instability or ligament laxity of the knee, ankle, or foot could benefit from strengthening the stabilizers of the joint. I see quite a lot of patients with Ehlers-Danlos syndrome and the associated hypermobility, and we seem to get reasonably good results with most people who undergo this treatment. So what are the knee stabilizers, for example? In that particular image on the left, you can see the quadriceps tendon, the patella tendon, the retinaculum, and the medial patellofemoral ligament, and the medial ligament itself with the pes-anserine tendon. Now you can imagine that any injection to thicken up these fibers would help on alignment and stability of the patella. The pes-anserine area also struggles quite significantly in OA knee and seems to respond very well to injections of dextrose. This is just an example of some of the markings that are used in teaching prolotherapy around the world. So how does it work? Well, it's an osmotic irritant. There is an effect on the membrane of the cells so that the cells are dehydrated and there's some membrane trauma creating an antigenic response. Also, the needling itself and fenestration creates a traumatic irritant to the connective tissues, as well as the chemical irritation from phenol when that's added. All of this leads to local tissue trauma and obviously some bleeding. The resulting inflammatory phase leads to a migration of phagocytes such as granulocytes and macrophages, and the release of chemical mediators. This leads to the secondary proliferation phase, where growth factors are released, frequently from platelets, such as transforming growth factor beta and connective tissue growth factor, platelet-derived growth factor, and other cytokines. There's further fibroblast migration and collagen deposition, and also the ability to form new vessels. The third phase is remodeling, where the early forms of collagen, type 3, actually develop and mature into type 1 collagen, and this resembles the original connective tissue. There is resulting ligament thickening and an increased ability to bear load, and actually an anabolic type of cartilage growth has been shown in animal studies. This is just a figurative diagram demonstrating the hypothesized mechanisms for pain relief. One is stimulation of local healing amongst intra and extra articular tissues, mostly connective tissue. Then the reduction in joint instability by strengthening these ligaments, reducing the instability and reducing the degenerative forces on the joint. Then stimulation of cell proliferation, again augmenting connective tissue. And finally, neuromodulation by desensitizing sensory nerves. Some animal studies have shown significant thickening of subsynovial connective tissue in rabbit carpal tunnels. Here's the subsynovial connective tissue layer, when saline is injected, and here's the subsynovial connective tissue layer when dextrose is injected. You can see a significant thickening on histological staining. These graphs also demonstrate an improvement in the load-bearing ability of connective tissue with dextrose compared to saline. So it seems likely that it's not just the needling effect, it's actually an effect of dextrose. These histological specimens on the right side demonstrate how fibroblast migration occurs after prolotherapy, and the fibroblast nuclei are visible in much higher numbers on the right-hand image. These fibroblasts then secrete fibrin, which turns into collagen. Okay, so before the 5-minute break, I'll set you a task, which is a case study of a 45-year-old lady who complains of lateral ankle pain, mostly on walking. She had a previous ankle injury several months ago, and it's never really got any better. The X-ray was normal at the time. And on examination, there was a full range of motion. She had a tender fibular gutter, just the distal end of the fibula on the anterior aspect, and some mild to moderate laxity on ATFL, anterior talofibular ligament testing, on the draw test, along with some pain on passive dorsiflexion, particularly while standing and doing a partial squat. Resisted movements were normal, and the external rotation stress test was negative. In standing, she had noticeable overpronation at her subtalar joints on both sides, with some synovial thickening and a possible effusion on the painful side. Ultrasound showed a grade 1 to 2 tear or disruption of the ATFL, but with normal calcaneofibular ligament and normal anterior inferior tibiofibular ligament. All tendon assessment on ultrasound was normal. And some questions I want you to consider is, do you need an MRI scan for this lady before you start treatment? As a matter of interest, if you did order a scan, the MRI scan only showed some injury to the ATFL ligament and mild synovial thickening in the fibular gutter. But the question you need to answer is, would you actually need to order an MRI scan before starting the treatment? Also, what is the differential diagnosis? And what treatment options do you have, conservative or interventional, to treat this lady? I will see you after you've had time to pause and reflect. And this is the second part of the lecture on prolotherapy, which was given on behalf of Queen Mary's University London and for podiatrists, physiotherapists, sport and exercise medicine physicians, and musculoskeletal physicians. Just as a matter of interest, on the first slide, you'll see a demonstration of the anterior draw test used for assessing ankle instability, particularly in patients with deficiency of the anterior talofibular ligament. If you look at the X-ray on the left side, talus is sitting nicely under the tibia, and when the draw is applied, a posterior force is applied to the tibia, an anterior force applied to the foot and the talus, then the talus is now sitting anterior of the fibula. That is a positive test and is likely to indicate anterior talofibular ligament disruption, tear or partial tear. And the other image showing some of the ecchymosis and bruising that might happen as a result of that type of injury. So before the break, I gave you a case study, a 45-year-old lady with a previous history of inversion ankle injury and a deficient ATFL, but no other significant injury. So hopefully you've come up with some diagnoses, and obviously the anterior talofibular ligament partial tear is the main diagnosis there, the resulting instability. But this patient also has some anterolateral or fibular impingement, which is often a result of the anterior talofibular ligament injury, where the fibula impinges on the talus in passive dorsiflexion. This may also be an indication of sinus tarsi syndrome, which is some disruption of the ligaments within the sinus tarsi that you can see here, and is often differentially diagnosed based on the site of tenderness, whether it's over the sinus tarsi or actually up against the border of the fibula. Now, you've excluded other causes, but you haven't yet had an MRI scan, because I don't believe the MRI scan is needed to start treatment in this case. There's the added expense, plus there is no other indication on this patient's history that any other injury has taken place. So one way of preventing the impingement is to correct the subtalar overpronation with orthotics, which will also be helped by giving the patient stabilizing exercises, proprioceptive stabilizing exercises, and low dye taping. So in this case, the patient's pain has improved, but it still persists, and she's come back to you saying it's still hurting. This is when you would consider ultrasound guided or blind, anatomically guided prolotherapy, dextrose prolotherapy injections using 15% dextrose into the area of the ATFL injury and into the sinus tarsi if necessary, and the pain usually will improve. Now, you could make an argument for steroid injections to reduce the inflammation, and they can also work, but it can be temporary. Does it make as much sense as strengthening and toughening the connective tissue of the ATFL? I don't think so. And therefore, you can choose steroid or prolotherapy injections. And if there's no help with that, then the MRI scan may be considered to exclude other pathologies such as osteochondral defects in the ankle joint. So there are many other sites that you can use prolotherapy, particularly the MCL, ATFL we've talked about, the calcaneofibular ligament, and the high ankle sprain, the anterior inferior tibiofibular ligament, can also be treated with prolotherapy, particularly if they have grade 1 or 2 tears. And there's the intertarsal ligaments of the foot. There is varying success with these in treating these ligaments, and some are backed up by studies and some are backed up just by anecdotal experience. The intervertebral ligaments are often treated, and certainly at the Blackberry Clinic we're doing a lot of prolotherapy in the lumbar spine and sacroiliac joints, the facet joint capsules, the iliolumbar ligaments, and supraspinous, interspinous ligaments. This can be extremely successful, particularly if the diagnosis is made correctly of a lumbar instability or a sacroiliac joint or pelvic girdle instability. You can also use Prolotherapy at the tibialis anterior insertion in the navicular, peroneus brevis, in the Achilles, and tib post at the insertions, particularly if you don't want to use steroid. Some people don't. There's been some work on intratendinous dextrose injections in Prolotherapy, in Achilles tendinopathy, and particularly some evidence on plantar fasciitis that it's helpful. There's a lot of work being done that's come out of Wisconsin, University of Wisconsin, by David Rubego, on intra-articular and extra-articular Prolotherapy in treatment of knee OA, with significant improvement compared to saline or normal therapy. It can be also used to treat the first MTP joint strain or pain, hallux valgus, bunions, and first CMC joint on the base of the thumb. More recently, there's been some research on perineural injections. Dr. John Liftoft from New Zealand has done some research and teaches on this subject using 5% dextrose solutions around nerve pathways for treatment of neuropathic pain. It has a particular effect on modulating the sensory A delta and C fibers and their ion channels, as I discussed earlier. More recently, again, there's been some work on perineural hydrodissection, particularly in carpal tunnel syndrome, by David Rubego and Dean Reeves. Now, here's some more specific examples of treating lateral ankle ligaments with Prolotherapy. Here's on the top left, a normal anterior talofibular ligament, showing there's the talus, there's a fibula, and normal fibular pattern of the ligament structure. Then with a chronic ATFL injury, you've got some neovascularization, you've got disruption and heterogeneous appearance and reflectivity of the area with some effusion just deep to the ligament. Now on this slide, you'll see some of the needle pathways where you can inject either end of the ATFL. And this ultrasound image shows some of the needle pathways to inject either end of the calcaneofibular ligament running under the peroneal tendons from fibula to calcaneus. In what is called comprehensive Prolotherapy, where several sites are injected, these are some of the other sites, like the bifurcate ligament, peroneus brevis insertion, intra-articular injection, the CFL, ATFL, AITFL, and the interosseous membrane can all be injected to stabilize the lateral ankle and prevent recurrent inversion injuries. Now, there's a lot of work being done in the past on lumbar instability, and here's a figurative diagram of some of the injection sites in the intervertebral ligaments, the interspinous, supraspinous ligaments, the facet joint capsule, the iliolumbar ligaments, either end, the posterior sacroiliac ligaments, and interosseous ligaments. These can be done in a 3-minute injection under image intensifier. And strengthening those intervertebral ligaments will assist the muscle stabilizers, the tonic and the phasic stabilizers, by the injection into the intervertebral ligaments, and the two structures together can have a significant effect on stabilizing lumbar spine, and several studies have shown a significant reduction in pain, often with associated physiotherapy-based lumbar stability exercises. In OA knee, but also other ligament injuries of the knee and other conditions, this is some of the teaching that is used by the Hackett, Hemel and Patterson Foundation and the Pain School International in Budapest. You'll see some of the coloured circles and arrows where the coronary ligaments can be injected, access to the intra-articular space, then the retinaculum, quadriceps tendon, and patella tendon. Then we've got the lateral side of the knee where the injection can be made along the lateral collateral ligament from origin to insertion, the anterior, the proximal tib fib joint, and then the coronary ligaments, along with Gerdy's tubercle at the insertion of the iliotibial band. On the medial side of the knee, you've got several sites of injection around the pes anserinus and bursal area, with the medial collateral ligament, origin and insertion, and the medial coronaries with the adductor tubercle. Popliteus insertion is often injected on the medial border, posterior border of the tibia also. Some other ultrasound images showing the medial collateral ligament being injected, medial patellofemoral ligament being injected at the patella, the origin in the patella. Then you've got medial collateral ligament being injected. And these are the other trajectories of the needle to inject several different structures under ultrasound on the medial side of the knee. Again, more diagrams on this slide showing injection points. And with such a complex arrangement of ligaments, you can see how you may be able to achieve better stabilization of the knee by thickening and strengthening these collagen fibers and ligament insertions. Here are some more drawings from the Hackett, Hemel, Patterson Foundation and Pain School International in Budapest over the lateral ankle ligaments, ATFL and AITFL, all of the ligaments responsible for stability of the lateral side of the ankle. Then the medial side, where overpronation can strain spring ligament, a short plantar ligament, along with the deltoid ligaments, which are often involved in external rotation ankle sprains. Again, there's the first MTP joint and the capsular ligaments that can be injected with dextrose, plantar fasciitis, and then evidence of other areas that can be injected, the medial plantar arch and the Achilles insertion. So why would you particularly want to use prolotherapy? Now, these are extremely strong reasons to use a particular technique, particularly if altogether they apply to one type of treatment. So, first of all, prolotherapy has been shown by several systematic reviews to be an effective treatment. In knee OA, in low back pain, in plantar fasciitis, and Achilles tendinopathy, all the reviews suggest that it is an effective treatment. It is also safe. There are some concerns about steroid injections, particularly if they're repeated, but there is no concern on repeated injection of dextrose. Several meta-analyses, in fact all of them, have shown it is a safe type of treatment to do. It is particularly inexpensive. A vial of 50% dextrose only costs a few pounds, and some lidocaine and saline is equally inexpensive. So those three are particularly good reasons to use one type of treatment. It is fairly easy, but you do have to have training. It is worth going to some of the training programs around the world and watching this type of treatment in action. It is also a useful adjunct to rehab. Muscles and ligaments stabilize joints. The physical therapies are extremely good at rehabbing muscles, but patients are not able to rehab their ligaments themselves. Orthotic inserts in shoes can definitely help to support the subtalar joints and control the joint. Taping can assist in the same way as can manual therapy. They can all be useful and should all be used as appropriate at the same time as doing prolotherapy. It's a good option if you found steroid has not helped. You may have used hyaluronic acid or autologous blood or PRP, and if there's been no result, steroid is there as a backup option as the patient sits in front of you and says, now what? What shall I do, doctor? What's next? I believe it's the first option of treatment in certain conditions such as lumbar instability or sacroiliac joint instability, which have not responded to physical therapies. There is some anecdotal interest from football physiotherapists who believe that in an acute ankle sprain, then dextrose prolotherapy can significantly shorten the time to return to play. And also, if I said that you had, I said earlier, some people have a concern over using steroid injections, particularly in the recent coronavirus crisis, or repeated use of steroid injections, which may have a detrimental effect to connective tissue. Dextrose prolotherapy has a positive effect on connective tissue and pain. Patients who have multiple pain sites, such as those with Ehlers-Danlos syndrome, and people with multiple trigger points, they might have fibromyalgia, it can also be a very successful form of treatment. So why would you not want to use prolotherapy? Maybe in an acute pain or injury, apart from ankle sprain, as I mentioned earlier. Some insurance companies, particularly Bupa, don't cover prolotherapy. It does need 3 to 6 treatments, 1 to 4 weeks apart. I tend to use 3 treatments, and if the condition is significantly improving, we can do more. It's used by family practitioners, GPs in the USA, and so maybe they have better availability of recurrent consultations, but it's certainly very popular in America and increasingly so in Australia and New Zealand. In some sites there is limited evidence of its effectiveness, but anecdotally it can be very useful. And as usual, more trials are needed. The trouble is dextrose prolotherapy has no patent. You can't get a patent on sugar, so there is no pharmaceutical company willing to spend money on large clinical trials and meta-analyses. So there is no particular other reason not to use prolotherapy. One of my colleagues said it is sports medicine's best kept secret, and I said, why is that? And he said, because it works, doesn't it? So where can you learn to do it? Well, the Hackett Hemwall Patterson Foundation in the US, American Association of Orthopedic Medicine in the US, Pain School International in Budapest, And the Blackberry Clinic group, Blackberry Education, have held courses in the past and are due to hold courses in the future, so do email me on that address if you're interested. So many thanks for listening, and for the benefit of the podiatrists amongst you, time wounds all heals, as we know. And at the end of this presentation, there are several slides of all of the evidence in vitro on the Achilles, systematic reviews and studies, systematic reviews in MSK pain, plantar fasciitis, and other references for you to peruse. Thank you very much for listening. It's been a pleasure sharing this with you, and by all means email me with any questions. Thank you.